So it is being recorded now. So we are going to record this and also live stream it to Facebook, and we'll send out the link. So it'll be uploaded to YouTube for you to watch later in case you're not able to make notes or you have to like head off downstairs to eat or something. So I can see the comments are starting to fill up. We are going to do a shout out there. We've got loads of comments from loads of you, 40 already. Let us know what school you're joining us from as well. So there's a couple of features in Zoom that you need to be aware of. There's a Q&A button at the bottom. If you press on the Q&A button, you can submit questions. And at the end, what we'll do is we'll answer those questions. Also, there is the chat box. So you obviously can type in comments into that. You can raise your hand. Some of you have already done it. So we only really use the raise your hand thing is when we're trying to do a poll. So for example, raise your hands if you're from London, and then we'll see, let's see what happens. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 9, 10. So 10, 11. Okay, so guys, if you lower your hands, what we'll do is, okay, raise your hands if you're from the Midlands, East or West Midlands, just raise your hands. Hands up, 6, 7, 17, 18, 19, 20, 22, 23, 24, 25. Okay, we'll do one more before Dr. Sandhu does a quick shout out. So just lower your hands. Okay, raise your hands if you're joining us from Wales or Scotland. 5, 6, Wales or Scotland, 7. Okay, 7, not bad. Okay, guys, so what Dr. Sandhu is now going to do, quick shout out for the names that have been typed into the box, and then we'll get started from there. So Vikas, over to you.
Perfect. So welcome, guys, to the Inspire Medics Get Into Medical School Ethics and Law Free Teaching webinar. Exciting bit. I always get excited. I can see that there's 109 people already logged in. I think there was 272 signing up. So keep it nice and short, guys. Let us know whereabouts in the country you are from and what year you're in at the moment. So I can already see that some of you have started. So we've got Darcy, who's from Studley, year 11. Zaid Khan from King Edward School in Birmingham. We've got Farshid from Real. Forgive me if I don't pronounce some of the names correctly. We've got Louisa Brown, who's a Liverpool undergraduate. Liverpool's my favourite football team. Well, alongside Coventry. Ahmed is a year 12 at the King Edward CHB. I think that's Birmingham. Fleur is in year 12. Umama is in Birmingham as a year 11. T is from year 12. Maddie. Emma Cohen, Scottish Borders graduate applicant. Fantastic, Emma. So I was also a postgraduate. So, but I was one of the youngest. So I think I was 21 when I applied for medicine after my physiotherapy degree, as you're all going to find out very shortly. Ella is a year 13 in Manchester. Honor is a Warwickshire, year 12. Ojas is a year 11 in Newcastle. Mohammed is Han, is Slough in year 12. Mohammed, Chester 13. Good. Great for a Saturday evening. Let us know. We will give you a shout out live medical entry preparation. So if you are doing it in here with us, so use it because you'll all be at different stages and you'll be able to support each other. And obviously we will be able to support you as well. Teach doctors from all over the world and different webinars, and they tell us where they are. The international ones are great because they tell about us in the world they're from. The GP trainees are also great, but you guys are interesting because you start chatting as well, which I really find interesting. You turn it in. That's Hannah, Johannes, welcome. I hope you're well. Dawood is the same, Anjali the same, Eloria same, Rakit the same, Alex Ramsey, Kenneth Foley Archer, Amelia Marshall.
So Vikas, just pause it there. You're buffering quite a lot, so there's a lot of interference with your line. I don't know if you want to switch off the Wi-Fi on your phone device and any other devices perhaps in your house. You're almost unhearable, I think.
Okay, let me just check what's going on here.
So guys, I take it you
how's it now?
Okay, that's better. Yes. Do you want to crack on?
Yeah. Good. Perfect. So, yes, Joseph, it will stay on the Facebook page and it will also go on our YouTube page. I'm assuming, guys, you can all hear me now. So if there's any problems, Mo, just interrupt me and I will get started then. So shout out's almost done. If you just enable me to share the screen and then I'll be able to make a start.
Guys, there might be a little bit of buffer on this. My side seems okay, so I'm based on a separate location to Dr. Sandhu. Dr. Sandhu is the doctor you see on screen. He's a UK GP, and then it's Dr. Mo you're hearing, who's also a UK GP. I'll be with you guys for the second half of the session, but for the first half, Dr. Sandhu will be doing his presentation. If it starts to lag, drop us a quick message or raise your hand. We'll try and sort out the technical issue. Vikas, over to you whenever you're ready.
Perfect. So good. Right. So. Let's get started. So we will give you a good overview. With all of our learning, we try to keep it simple, specific, and straight to the point. So I know that many of you, well, you're all at different stages, actually. Some of you will be preparing for interviews. We've done some interviews with some potential medical students, in recent weeks. And of course, some of you are further back, so you're thinking of applying for medical school. I can see year 11s and so forth, which is very good because it shows that you're planning ahead. And we want to make sure that you gain the most and you get yourself ready. It's a very long road. So medical school, like it said, it starts off whether you're doing it as an undergraduate from your GCSEs or if you're going as a postgraduate. It's a long road from sixth form all the way down to medical school and then onto your junior doctor years and then onto whether or a specialist in the hospital. There's lots of exams, there's lots of ups and downs, and sometimes the path is not very clear. So the purpose of iMedics is to make that path clearer for you so you understand what's my story and why is it relevant. So some of you may have seen us on other webinars, but I know that lots of new people join, so it's important that we tell you what our backgrounds are so that you can put our stories into context. And both me and Dr. Mo are both very different in our routes to medicine. He will talk about his a little bit later on, but the purpose is to let you know that if I can do it, you can. So as a GCSE student, I wasn't all that. I was just an average student, maybe a few A's, mainly B's and C's, even the odd D grade. A levels, 2 A's and a C, but it was, again, not really anything specific to kind of chemistry and physics and maths like many of you will be doing. And I wasn't actually going to do medicine anyway. So at A level, I was kind of into science, really liked sports. Physiotherapy was a natural route. So I ended up at the University of Birmingham back in 2007 as a fresh-faced 17-year-old. And I was started my physiotherapy degree, scored a 2-1, which was well enough, just what you needed basically to get onto medicine. But initially I was told that you need to have more clinical experience, i.e. the degree's not enough. And obviously you guys know the criteria changes. So I did a master's in sports medicine, sports physio, and got a merit with that. Staying on, that was at the University of Birmingham as well. And then during that master's, I made a second attempt for the graduate entry medicine program. And I was accepted in Leicester. And obviously I completed that back in 2012. Since then, of course, been a junior doctor. So I worked in Leicester as a junior doctor at the Glenfield Hospital doing cardiology, the Leicester Royal Infirmary doing acute medicine, dermatology, obstetrics and gynecology. I spent 4 months doing academic research. I did respiratory medicine and general practice. And then, of course, I went on to GP training in my home city of Coventry, where I did different posts. So spent some great posts doing hematology and oncology with medicine on call, pediatrics, and ear, nose and throat, followed by 18 months of general practice. And to go from here, where I was a fresh-faced, probably didn't really know where I was going and quite an average student, I passed my final GP exam, my exit exam in London, and became a member of the Royal College of General Practice with a score of 95 over 117, which was one of the highest scores in the country for that sitting. The moral of that story is if I can do it, then all of you guys who are attending this webinar can also do it regardless of your background and academic aptitude. This was just a hard, long journey. It was just hard work, but it was possible. So you can all achieve that as well. 2019, so last year, so iMedX was founded in 2017. It was an online medical education platform that was designed to support medical students, junior doctors, GP trainees, and also international doctors who want to work in the UK. It started off as a very small project, but with lots of hours between me and Dr. Mo, as well as working as GPs. But the company was recognised, and we got the recognition for all the hard work. So I'm now on the NHS England clinical entrepreneur program. So it's been a very long journey, but now things are opening up. We've got 12,000 doctors registered all over the world, and the company is very big. We're still practicing doctors as well, but we now have a team around us. But everything is there for you to achieve as well at the start of your journey. So what are we going to do? So today we're going to talk about ethics, and then specifically we'll break down things to make it nice and simple. So what are the key definitions? What are the key ethical principles that you need to know? And we'll use some examples to give you a framework to have when you're answering ethical stations, whether you're doing a panel interview or an MMI, the newer format of interviews, it's very likely that you will get an ethical scenario. So you need to know how to be able to handle that. And obviously the urgency of how quickly you learn that just depends on what stage of your training you are at. So definitions. So the key thing, there's two things to remember. So firstly, what is medical ethics? So ethics is just a generic term to describe and values and principles that we should apply to clinical medicine, scientific research, and just generally in life as well. Then you've got the GMC. So the GMC is the GMC has something called the Good Medical Practice Guidance, which you can Google. It's a free document. It's worth having a read, and it sets out the guidelines that doctors and medical students must abide by to avoid bringing the profession into disrepute. And obviously, the GMC looks at and analyzes doctors in 4 key ways. Firstly, it looks to make sure you keep your knowledge, skills, and performance up to date. So as doctors, our knowledge is constantly evolving. The guidelines for different conditions changes. So every 12 months, every doctor has to have an appraisal where they have to show 50 hours worth of learning. And that can be through courses, through teaching, through cases you've seen, through clinical incidents, and so forth. Number 2, safety and quality. So we have to demonstrate in a number of ways. For example, assessments from your colleagues, learning from mistakes. Number 3, communication, partnership, and teamwork. So they look at your the way you communicate with members of the team. You often have what we call multifaceted assessment forms. So teams that I work with, for example, will fill in a form. It'd be nurses, receptionists, physios, doctors, and they'll just talk about kind of, how I've been over those the last 12 months. Maintaining a bit of spelling error there, ignore the double M, but it's maintaining trust. So maintaining trust in the profession. So these are the 4 key domains that the GMC oversees. Every doctor who practices in the UK has to be registered with the GMC. If you make serious errors or get serious complaints, they can also remove you from the register. There is a difference though. So laws are basically rules and regulations that the government sets. So for example, there'll be lots of rules that are the laws that are in place that if you break them, you are breaking the law. You can go to jail, you can go to prison, and so forth. Ethics, as we've said, are values and morals that we should have enriched inside us, which we use when we're working as clinicians with our patients, but also in day-to-day life. And as I said, the GMC is more kind of ethical, so it focuses on ethics, and they kind of guide the ethics that doctors and medical students need to have in the UK. So there are 4 ethical principles that you need to be mindful of. You may have heard of these before, but whatever you do, get them into your head now. You may even get a simple question such as, can you tell me what the 4 ethical principles are that underpin ethics? And they're quite simple. They're summarized on this side for you in this slide. Number 1, you've got autonomy. That is the ability that we give to our patients to make their own decisions. So we consider their wishes of what they want from their treatment, from their investigations. Now sometimes, they may have a wish which goes against what you think is right, but the autonomy principle is that we have to respect that decision. If you think there's an issue, then you can assess the capacity. If they do something illegal, which is different, like euthanasia, and I know Dr. Mo is going to talk about some of those topics later, then of course, you know, you go by law. For example, euthanasia is illegal in the UK, but of course it's legal in other parts of the world like Switzerland. So you review the situation, but in essence, we have to respect what the wishes of our patients are. The second key principle is the principle of beneficence. And that's trying to make sure that anything that we do, whether it's an investigation or whether it's management, it's done in the best interest of our patients. Number 3 is non-maleficence, and that's basically making sure that anything that we do, whether that's a procedure or a management, a treatment, we don't cause harm to our patients. And number 4 is justice, which means you treat your patients fairly, taking into account lots of things, socio-economic factors, religious factors, cultural factors, making sure that we don't treat anybody differently because of the way they are, whether it's the same as you or different to you. So let's take an example of an ethical case. So here's a scenario. So, some of you may be in an interview in the next few weeks. You may stand outside the door and you may see your MMI station 1, and it might give you a statement like this, which is the NHS is now really struggling with financial pressures. Smoking is a big risk factor for the development of a number of diseases, things like COPD and ischemic heart disease, to name but a few. Should smokers be treated on the NHS? You've got 5 minutes or 10 minutes to discuss this, please, when you go into the panel. So you may have 30 seconds to digest this information, and then you've got to think, right, what am I going to do here? Should smokers be treated on the NHS? Gosh. So you need to have a structure. So you could go back to this again. So the 4 ethical, because this is an ethical question, isn't it? Should smokers be treated on the NHS? So we go back to our 4 ethical principles of autonomy, beneficence, non-maleficence, and justice. And we have to apply it where possible. Now, you may not be able to apply it all the way, but we have to apply it where we can. So let's think about it. So let's acknowledge the question. So we go back and we say, okay, so yes, you've just mentioned that the NHS is really struggling. There's a lot of things going on. Okay, what could we do? So you can say, well, okay, the way I'd like to answer this is using the ethical framework, for example, autonomy. So patients often make the active decision to smoke, but there are a number of other things that could be influencing them. For example, we don't know what's going on in that person's life. They may have stress, they may have a bereavement, they may have issues at work, they may have problems with their family. They may have tried to quit previously, but because they become addicted to smoking, it becomes very difficult for them to stop. Now, the previous quit attempt is interesting because they've engaged with an NHS service, the Stop Smoking service, but they haven't managed to stop. Does that mean that we should just say to them, well, okay, you can't, you don't deserve to smoke? I'm not really sure. You might then move on to the second principle. So 2 and 3 can be joined together. Should they be treated on the NHS? Well, what's the benefit? Well, the NHS is free at the point of entry. That's one of the main things why people all over the world recognize Britain. If you talk about Britain, one of the key things people say is the NHS is a fantastic service and it's free at the point of entry. Not many countries can actually say that. There is, of course, other things, for example, finances. So if we said to smokers, you have to pay for your treatment, if smokers came from a lower socioeconomic background, they may not be able to afford their treatment. They may not be able to afford to have scans and tests and see a GP, go to the hospital, have surgery done and so forth. And therefore, we will then have this inequality in healthcare. And of course, there's a possibility of increased risk of mortality. And then there's the 4th principle of justice. So you can say, now, of course, smokers pay taxes. Some of them would have paid taxes all their lives, depending on their age. And of course, cigarettes themselves, the companies are taxed as well. That money goes towards lots of different services within the NHS and across the country. And it's therefore very harsh for us to deprive smokers of their, of the NHS services. You can signpost to the fact that you want to make sure that everybody deserves a chance, not a change, a chance, and talk about the NHS as a success story. And then you can just summarize and conclude. So to summarize, you can see that there are some people who would say that yes, smoking is a voluntary thing. People make the active decision. and therefore they should be accountable for their decisions. But on the other hand, I can also see that actually they contribute a lot to society. They've paid their taxes. They may have tried to quit before. There may be lots of factors that are going on in their life which are making them smoke. And actually, if we work with them, we may improve their long-term outcome. So that's the kind of way you would tackle such a scenario. Summarize and conclude. You don't have to commit to anything, guys. So remember, even from today, you've told us some of you are year 11, some are year 12, some are year 13. You're not expected to suddenly make a huge decision with limited medical experience. So the key thing is, some students, when they go to the interview, they think just because the panel are putting them under pressure that they're expected to commit to one side or the other. Don't have to do either, as long as you show balance, a bit of reasoning, some arguments for, some arguments against, and then sitting nicely in the middle when you come to the end. Let's take a second example just to see if we can actually apply the principles again. So you've got a scenario here. You've got Mr. Gerald Smith. He's a 60 male, and he's come in to see his GP for his recent chest X-ray results. He had presented with recurrent chesty cough, which did not improve after 2 courses of antibiotics. His chest X-ray report mentions a suspicious mass in his right upper lobe, and an urgent referral to the lung cancer clinic is advised. Mr. Smith refuses to be referred. Please explain how you will manage this situation. So again, you've got to go into that zone of looking at the principles. So autonomy, beneficence, non-maleficence, and justice. So let's apply them. So autonomy, the ethical framework. So firstly, does he understand the risks of not being, does he understand the information that he's been told? Now, you can say this to the panel. So the first thing that I would like to do, looking at the panel, is I'd like to make sure that Mr. Smith actually understands what he's been told about his current symptoms and his X-ray report, and whether he understands what the implication is. Does he accept the risk? So, so you may want to discuss with him that, look, if we did not refer you and this mass does turn out to be a lung cancer, this could be fatal for you. Do you understand that risk? Now, of course, he does have the right to decide about his care. It might be a case of, you would say to the panel that, look, we may need to explore why he doesn't want to be referred. Maybe he's had a negative experience at the hospital before. Maybe he's been to the lung cancer clinic and they did a biopsy and they caused a problem or a complication, or he felt the staff were rude, and there's something there which is acting as a barrier for him to go in. So we can explore that. So that's where the autonomy principle comes in. And then you're showing the panel, you're saying, okay, and then there's a couple of other principles of ethics that I'm thinking about, such as, for example, the benefit and the risk of doing no harm. We know that there's a suspicious mass on the X-ray. We know it could be lung cancer. And we also know that specialist assessment would be in his interest. If we refer him early, he'll obviously be diagnosed early, and then he can be started on treatment. So we can work out, again, combining what we've said here, we can clarify the reasons for his refusal, might be his previous experience, and then we can perhaps work on trying to overcome those issues in the referral letter. We can say, last time, the nurse was very rude to him, or he felt that the consultant was a bit derogatory, or was too it caused him a lot of discomfort when they did a blood test. And so this can be put part of his referral, and therefore we can try and overcome his concerns. And justice. So he's got 2 weeks. Now, that doesn't mean that, he may decide, actually, I just need some time, doctor. So we can say, to make sure we treat him fairly and he doesn't make a rash decision today in the clinic, we could say to him, well, why don't you go away, Mr. Smith, have a chat with your family. If he's married, if he's got his wife or kids at home, have a chat with them, see what they think. We could offer him a follow-up in the next few days to bring him back. We can give him some further information to read. So there's a number of things that we can do, and then we can bring Mr. Smith back, and we can come up with a shared decision within an ethical framework to make sure that he makes the right decision. If we delay his referral by 4 to 5 days, that's better than not referring him at all, because then at least he can still get his diagnosis and treatment. So that is, we'll stop the share at that stage. So Dr. Mo, if you're there, so I can see some questions coming up. I think they're all about YouTube, aren't they? Okay, so yes, so that was basically that. The two webinars are going to merge into one, because Dr. Mo's going to move on to the next stage of ethics. Once you've done it all, it should make sense. But there was a few take-home messages there, which is use the 4 ethical principles, know about them. I mean, you've got it. You can see this webinar back on our YouTube channel on Monday and in the Facebook group. I'm going to put the link in now, actually, but use it, because what you want to do is apply that knowledge to any ethical scenario that you get, because this is one of the reasons why people find it so difficult. So let's see, a couple of questions coming up then. So Manahal said, in your answer, should you talk about the medical ethics by naming them as well? Why not? That's a really good thing to do. That shows that you've got the knowledge. Now, they may already, if it's a chat-based MMI, they may actually ask you, what are the 4 principles? And you're going to list them off. But actually, if you can show reasoning, so remember, the purpose of an interview is you're trying to show the panel what your thought process is. So you want to be thinking autonomy, beneficence, non-maleficence, and so forth. And you're showing the panel that you know what the 4 ethical principles are, and you would use that in your decision making. You would actually score higher if you did that. So, but a very good question. Then Teabag's got a question. If people were being rude to him in the clinic, would we include this in the referral letter to the lung clinic? I mean, or could this make things worse for him? Absolutely. So you can include that information. So you can say that, look, Mr. Smith, now remember, you're discussing this. You're not actually actively doing the task. So you're discussing with the panel. You could say that Mr. Smith may have had a really bad experience at the lung clinic, or, the hospital in general last time he went, and therefore, he specifically mentioned, and we can mention that in a referral letter, that, look, he felt that the nurse was rude, or he felt the doctor was rude, or he felt that, they had 6 goes at the blood test, and therefore the hospital will be more mindful when they see him in. Good.
So Vikas, we've got 1 or 2 other questions, which is, what if he does not agree to referral even after efforts made by the doctor?
Good question. Hold on. So where is that, from the bottom, or
the Q&A icon?
Okay. So the theory, remember, you guys have to be, so you're going to say to him, firstly, we're going to give him time. So we're not going to say to him today, right, you've got to go. He says no, right, okay, then that's fine. We will give him the option. We'll give him the opportunity to come back, discuss with his family, and then he can come up with a management plan. Eventually, if he keeps on refusing, he is within his right, as long as he has capacity and he understands the decision and he accepts the risk. You can't force him to go. But what you can do is you can say, okay, well, look, if you change your mind, Mr. Smith, you can get in touch with the doctor's surgery, and he can get referred once he feels right. I think you'd agree with that, Dr. Mo.
Yeah, absolutely. Yeah, I'd agree with Dr. Sandhu on that. And the 4 principles that Dr. Sandhu touched on are the key principles that they're looking for. And there are 3 additional principles, which we're now going to talk about in the second half. So Vikas, there are a few other questions, but I think we're at the halfway point. We can cumulatively tackle some of the other questions a bit later on.
Yeah, fair enough. Yeah.
Okay, guys, one small request. Like, we do this webinar for free. We don't charge you for this. And we've been doing this now, I think, for the last couple of months. We've done a personal statement webinar, and we did an interviews webinar as well. If you don't mind, I'm going to put in a link for Google down at the bottom of the chat. If you could kindly just leave us a free review on Google for us, a nice review, hopefully, rather than a horrible or mean one. This allows us to obviously get brand awareness to other aspiring doctors like yourselves, who can obviously come onto these webinars and benefit from the free webinars and the knowledge that we have. There's not many GPs out there like myself or Dr. Sandhu who take their evening out on a Saturday to come, and talk about ethical topics or how to get into medicine. And so if you don't mind, if you appreciate that, just click on the link. It'll literally take 20 seconds, put in a nice review for us. And this helps, as I said, with getting awareness to other doctors. So without further ado, I'm going to do a screen share, because we are now going to talk a bit about the second half of this topic, which is ethics and law, and it's relevant for how you get into medical school, of course. So if you give me a second. Okay, good. So a bit about myself. Some of you already know me. For those who don't, my name's Dr. Mo. I'm a UK GP. I've been a doctor now for about 10 years. And my journey was quite different to Dr. Sandhu. So Dr. Sandhu is a postgraduate and he went into medicine via the postgraduate route, whereas I went into medicine via the undergraduate route. So I went to a local inner city comprehensive school in Coventry. It's called Sydney Stringer. Had to work really hard, which I figure most of you are already doing, if not, if you haven't done for the last few years. I did relatively well at GCSEs. I know you got a new grading system now. I'm quite old compared to you guys. But then I did A-levels. I did 4 A-levels, and in hindsight, I probably only needed 3, but I got A's for all my A-levels. And then I moved on to Birmingham Medical School. I was luckily accepted out of the 4 universities I applied to. I did get interviewed at Oxford, but the Oxford interview was so tough. And they did 4 interviews on the same day. And then after I finished my medical degree, I moved on and became a junior doctor in the East Midlands, Northampton and Leicester. I did that for 2 years. I did various different rotations, including colorectal, acute medicine, and urology. And then I moved back to Coventry to do my GP training for 3 years. And then I got my licensing. And now I've been working as a GP for 5 years, coming on to 4 or 5 years. So that's a bit about my journey. It's a more traditional journey, perhaps compared to a postgraduate. But it's still important to know so that you understand how long the career pathway is and how much dedication you have to put in. Because along the way, I failed multiple exams, which you have to resit, which isn't uncommon in medicine because the exams are so tough. And of course, getting into medicine in the first place is so hard. So just remember, it's a marathon. Don't treat it as a sprint. It's a 10, 15, 20-year journey for most doctors. So let's just recap. Dr. Sandhu covered 4 key principles. Some of you had questions, you wanted clarification. So let's clarify what those principles are. Autonomy is the ability or the freedom to act independently. That basically means, so I have autonomy, I can do what I want. So I'm going to lift this pen up and I'm going to drop it down. And I've got the freedom to act independently. Nobody could tell me what to do with this pen or what not to do with it. That's autonomy, having the choice, the freedom to do what you want. Beneficence is to do good. It's the act of doing good or promoting good. Non-maleficence is to not harm, i.e. not cause injury to an individual. And then justice is to treat everybody fairly and equally. So that's a quick recap, because the next important thing is we need to talk about the big C's. And this is really important for ethics and law in medicine. So what are the 3 big C's? So the first one is confidentiality. You've all heard of this, but what does it mean? It means not to disclose information. That's basically what it means. So if you get an interview question on it, confidentiality means not to disclose information. We're going to cover this in a lot more detail in the next couple of slides. Consent is to give valid permission. Consent isn't to give permission, it's actually to give valid permission. So you can get permission which is not valid, and it's not consent. And again, I'll cover that in a lot more detail shortly. And then finally, capacity is the ability to give valid permission, i.e. the ability to give valid consent. So not everybody has capacity, and you have to assess it. Again, I'm going to break it down in the next 3 slides. So let's start off with confidentiality. So what's confidentiality? It's the doctor's or the healthcare professional's role not to disclose information. So if somebody comes to me as a patient and they tell me that they're HIV positive, or let's say, HIV positive, as a doctor, I'm under an obligation not to disclose that information to my family, to my friends. I may disclose it or discuss it amongst healthcare professionals, but then they are bound by confidentiality rules and regulations as well. And it ensures privacy. Like, how many of you want your private information known to the world? You don't, because it's private, it's personal to you. So if you've ever had athlete's foot or eczema or asthma, do you really want someone else knowing that you've had athlete's foot in 2014? Probably not. That's the reason why privacy is so important. However, whilst it's a big topic and it's very, very important to make sure that confidentiality is not broken, that you maintain confidentiality both as medical students, if you're at a work experience and you're observing, or you're a healthcare professional like a doctor, there are rare circumstances where you can break confidentiality. And those rare circumstances are if the patient gives you permission. So they say, yep, you can discuss it with my wife, fine. If the patient lacks capacity, and we'll come on to capacity soon, but capacity is when somebody is perhaps unable to make a decision, maybe because they're confused or they have dementia, but they'd benefit from that disclosure. So let's say there's an elderly lady at home who keeps on having falls and she has dementia. It's in her best interest, perhaps, if I disclose that to a close family, so that maybe she needs a better social package around her, so that somebody can pop in, or she's moved to a nursing home or a residential home. There may be, or I need to discuss it with social services. So that's when you can break capacity, break confidentiality in the best interest of a person who lacks capacity. Also, sometimes you need to break capacity to prevent public harm. Sometimes in clinic, we may see a patient who's psychotic and they want to, let's say, kill somebody kill somebody because they're having thoughts, they're having these voices in their head. Therefore, it's my role and my duty as a doctor to inform the police or social services that this person is having these thoughts and they may want to act on them, and it's in the best interest of the public. Then there's safeguarding. So safeguarding is things to do with where either the law has been broken or there's an issue with domestic violence. So let's say a male person in the household hits a female person in the household, his partner, but there's children involved. Because of that, we have to break confidentiality and inform social services because of the kids, because of the domestic violence that's occurring. And then finally, sometimes the law intervenes. So the law, if you get a court order to give information, you may need to break confidentiality for that reason. So if the law intervenes. So those are the couple of exceptions, but the general rule is you do not break confidentiality. Number two, consent. So consent is giving permission. For example, does the patient give you permission for you to speak to them? That's consent. Has the patient given you permission to take blood? That's consent. You have to get permission from that patient before you do something. Now, there's three types of consent you need to be aware of. Voluntary, where the patient is saying, yep, no problem, you can do it. And a good example would be, Mrs. Smith, may I speak to you? She says yes, that's voluntary consent. Informed consent, that's more like when you are going to do an operation on a patient and you have to get informed consent. So you tell them what the risks are, the benefits are, why you're doing the procedure, any complications, and what they can expect during, before, during, and after the procedure. That's called informed consent. And then the patient usually signs a consent form. And then the other thing to think about, which ties in with the next slide, if they're able to give valid permission, do they have capacity? I.e., are they able to give consent? Because not everybody's able to give consent. Like Alzheimer patients, severe Alzheimer, severe dementia, they're confused. Maybe they're not able to give valid permission. And we'll come on to capacity very soon, so you understand what valid permission means. There are three types of consent you can give. One is written, one is verbal, one is non-verbal. Written, so you're going in for an appendectomy operation, you have to give written consent once the surgeons explain the procedure to you. Verbal could be, Mrs. Smith, can I please ask you a few questions? I'm a medical student. Yes, you may. Verbal consent. And then finally, non-verbal is, Mr. Smith, may I check your blood pressure? And he puts his arm out in front of you. He doesn't say anything, but non-verbally, he's given you consent. So that's the second big C. The third big C is capacity. This is very important. It's the ability to give valid permission, and not everybody has capacity. So there are 4 key domains that must be fulfilled in order for a patient or an individual to have capacity and give valid permission. So the first domain is to understand the information. Can the patient understand the information you're giving them? Number 2, are they able to remember the information for the duration that they're able to weigh up the risk factors, the risks and the benefits, and then communicate it? So they have to be able to remember it. If you give them a piece of information and say, Mr. Smith, the risk of the risk of death during an appendectomy is 2%, and the patient suddenly forgets it within 10 seconds, they don't have capacity. Thirdly, the patient has to be able to weigh up the risks and benefits of the information you've given them to reach that decision. So they have to go, okay, Dr. Mo said this and this, the pros and the cons, I'm going to weigh it up in my head. And then finally, the fourth thing that enables a patient to have capacity is the ability to communicate that information, whether it's verbally or written or by any other forms or means like WhatsApp. Although that's not a good example, but I'm just saying they need to communicate it. So if they have those 4 key domains and they're able to demonstrate that patient has capacity and he or she can give valid permission to you for whatever procedure or medical thing that's going to occur, whether it's checking blood pressure, giving or taking blood, or taking medication, for example. If the patient does not have capacity, then what happens is you have to take the best interests, their best interests to heart. So what that means is you have to act in their best interest, which is the ethical aspect of beneficence, to do good. Where are we? Okay. And then if they don't have capacity, what normally happens is that the patient gets an independent mental capacity advocate, somebody who takes or is able to make decisions on their behalf in their best interest, so they can get a representative. And finally, the other thing that can happen if the patient doesn't have capacity is that they may have something called an advance directive. What that means is they may have something like a written piece of paper which has been signed in the presence of a witness, which says what would happen during a certain situation. So let's say I don't have capacity now because Dr. Mo's developed dementia, but 2 years ago, I wrote in my will, for example, as an advance directive, if I ever develop dementia and I'm not able to have capacity, I do not want to be resuscitated if I have a heart attack or stroke. So that then means that's an advance directive. Even though I don't have capacity now, I wrote it earlier on before I came to that point when I didn't have capacity. So those are the big C's. I'm just going to recap for you. The 4 key ethical principles which you should discuss during an interview process if you have an ethical dilemma is autonomy, beneficence, non-maleficence, and justice. Then don't forget, if where possible, you get the 3 big C's that may tie in. I'll give you 2 examples: confidentiality, consent, and capacity. Tie them in where appropriate. So let's talk about a real life case example. So euthanasia. Euthanasia is basically a process where somebody wants to end their life, i.e. they want to basically commit suicide and kill themselves. In the UK, it's illegal, it's not allowed, but in other countries, it is allowed. For example, Switzerland. There are a couple of key ethical principles involved if you ever get asked this question during a medical school interview. Those 4 principles are autonomy, beneficence, non-maleficence, and confidentiality. Let's break it down relevant to the ethical dilemma which we're presenting. So autonomy. First of all, if I'm a patient, I can choose whether I want to kill myself or not. I have free choice. So that's the first ethical point that's worth mentioning in respect to the pros and cons of euthanasia. With regards to beneficence, the doctors have a duty to do good. Therefore, they shouldn't be killing off patients or taking their lives. So beneficence plays a part where the doctor shouldn't be obviously causing the patient any harm. That's the second ethical dilemma. The third ethical dilemma is to do no harm. So beneficence is to do good. So to do good would be to prolong the patient's life, but also to prevent suffering. And if you think of euthanasia as ending a patient's life to stop suffering, you could classify that as doing good. But then non-maleficence says that you shouldn't do harm, i.e. you shouldn't kill off a patient or end their life. So there's 2 opposing ethical dilemmas which collide. And then finally, there's confidentiality, which also plays a part. So if a patient tells you that they're going to commit euthanasia in the UK, then that's illegal, and you may need to inform the patient and of course break confidentiality if they want to commit suicide. Let's say tomorrow they're going to jump in front of a railway train to end their life because they think that's going to be euthanasia, then you may need to break the law and inform the police services so that does not occur. And that's one of the examples where you can break the law. So those are the 4 key principles with regards to euthanasia: autonomy, beneficence, non-maleficence, and confidentiality. Let's move on to DNARs. So what's the DNAR in the UK and across the world? It's a do not attempt resuscitation order, which is a legal document, which means that if a patient's heart stops, that you must not start chest compressions or basic life support. Now, there are 4, again, key principles involved here: autonomy, beneficence, non-maleficence, justice, and consent/capacity, which are applicable to this topic. Just want to keep an eye on the time here. Good, we're doing fine for time. So guys, don't forget, if you could kindly leave us a Google review. We do this for free. You're learning tons of information. The link's in the chat. Just leave us a nice review. This helps us with the branding and getting the exposure to other aspiring doctors. And of course, it'd be a big favor to us, which we'd really appreciate. Okay, coming back to DNAR. So autonomy. I, as a patient, should have the choice whether or not, if my heart stops, a doctor or a healthcare professional should start resuscitation. Like, I should have the choice. But the dilemma here is that the doctors usually make the decisions about DNARs. They may decide that it is not in the best interest of a patient to have cardiopulmonary resuscitation, i.e. chest compressions, because it's going to cause harm. Broken ribs, damaged spleen, ruptured liver, ruptured spleen, damaged liver. And so the patient doesn't always get autonomy in these types of decisions. So the patient can say, and have the healthcare professional can have a discussion with the patient and say, you know, we're not going to do resuscitation because of XYZ disease that you have, and we don't think it'll be successful. And in that instance, the patient does not have free choice, because they can't say, oh yes, I definitely want to be resuscitated. So there's a question mark over autonomy with DNAR statuses and protocols. Secondly, beneficence. The doctor should do good. The doctor should preserve the patient's life, which means that all patients should have chest compressions done if their heart stops. But the truth is, that's not always possible. So again, beneficence, doing good, all patients should have chest compressions. In reality, it's not feasible, and I'll explain why with non-maleficence. So with non-maleficence, you should not do any harm. And the chances of surviving or getting your heart to restart with chest compressions is usually about 10%, 1 in 10. If that, I mean, that's like the best studies. So if you're not able to restart the patient's heart and they're not able to come back to life, the damage that you usually end up causing is, if they do come back to life, is that they'll have broken ribs. So first of all, there's they may not come back to life in the first place. But even if they do come back to life and their heart restarts, you're likely to have broken their ribs, spleen trauma, liver trauma, bruises. I mean, there's so many injuries you can cause whilst doing chest compressions. Is that really doing the patient no harm? Probably you're causing the harm in that case. Then there's the principle of justice, you need to be fair with all patients. So why is it that perhaps an elderly patient should not